This is Amy Gibson from the Patient-Centered Primary Care Collaborative. Welcome to our webinar today on assessing the practice in partnership with patients and families. As many of you know, this webinar is part of a long series of webinars that we just really kicked off in the last month. But these are going to be many monthly opportunities for you to learn more about how to really truly partner with patients and families as part of practice transformation. And this is all supported by our grant as a support and alignment network through the Transforming Clinical Practices initiative that is sponsored by CMS. We're very excited to have our key partner with us in this initiative, the Institute for Patient and Family Centered Care, leading our webinar today. We're especially excited that we have someone from Peace Health who will also be presenting today. Peace Health is also represented as a practice transformation network in the TCTI initiative. So you're going to get a lot of fantastic information today on some very specific strategies on ways to get started and really activate your patient partners in your care delivery redesign efforts as part of TCTI. But for those of you who are not formally part of this initiative, we want to be there to support your activities as well. All of the resources that we talk about on today's webinar, as well as many more, are available on the PCPCC website. You can get there at pcpcc.org. Click on the Practice Transformation tab. In addition to the information that you're going to get from today and the downloadable materials, we also will have archived a full recording of this webinar that'll be available tomorrow there. But as you peruse all of those resources, you're going to see a few other things that I just want to draw your attention to very quickly. For all of you who already have patients from your practice that you've identified as partners, please encourage them to sign up and join the PSAC network. This is going to be a virtual community of all the patient and family partners around the country. A great chance for them to talk to one another, ask questions, get support through our support and alignment network in their efforts to work as partners in clinical transformation. And then for those of you who have already been working with patients and families, congratulations, you guys are the early adopters. Tell us your story. Let us know about what you're doing. We have a web form that's available up on our website that we encourage you to fill out. Tell us about your practice, how you're partnering with patients and families. We want to draw some national attention to the work that you're already doing in your practice. Eventually, we'll have a very exciting map for everyone to go and find out about these various strategies for engaging patients and families. And hopefully the patients that you're working with will then want to serve as mentors for other practices. So I don't want to take up too much time. I want to go ahead and turn it over to our presenters today. Mary's going to be also our moderator, and she's going to give you some instructions for how to ask questions throughout the presentation. So Mary, go ahead and take it away.
Great. Thanks, Amy, and welcome, everyone. I'm so excited to be able to moderate this webinar. You have some amazing content experts joining us, and I'll tell you a little bit about them in a moment. But first, a few logistics. So copies of the materials and the presentation are going to be available on the SAN website, and that URL should be appearing in the chat room very shortly if it's not already there. We're going to use the majority of this next hour till about 5 to 2 for our presenters to share content, examples, experiences, and practical tips and tools. During that time, however, I really encourage you strongly to chat, and any questions you have related to working with patients and families and assessing the practice. About 5 minutes before 2, we're going to recognize that some of you are going to need to leave. We'll answer a couple questions at that point. And then for those of you that need to leave, that's fine. We know you have other things to do. But we are going to have a half hour from 2 to 2:30 Eastern Time for you to ask questions and for me to share the chatted questions in so that our presenters who have extreme content knowledge can answer those questions. Everything related to the webinar, including that Q&A session, will be recorded. So for those of you that can't stay but really want to know what some of the questions were and what the additional content and the richness of that effort is, you can get back to the website and listen to that part of the webinar. So let me introduce our presenters today. Both work with IPFCC as faculty at a number of our educational sessions, and we bring people who have actual lived experience in working in partnership with healthcare and with patients and family advisors. Juliet Schlechter has more than 2 decades of experience working with and leading healthcare professionals in patient and family care assessments, programming, design, and implementation. She's consulted on a number of these topics related to quality, safety, and outcomes related to working with patients and families. She continues her work by working currently as the director of the Center for Child Experience at the Salal Institute for Child and Family Centered Care at NYU Langone Medical Center. She has provided leadership for many years, from the Children's Hospital of Philadelphia to working with the American Academy of Pediatrics on family-centered home care, and she has been involved in many national efforts. Patty Black is the program coordinator for the Patient Advisory Council for Peace Health Medical Group in Eugene, Oregon, but she began this work as a volunteer patient advisor for Peace Health Medical Group based on her experience of receiving less than adequate health care that resulted in some life-threatening experiences. So she's developed a passion for patient-provider partnerships, positive partnerships, and bringing the voice of patients and families to the table. She's also served on the Oregon State Task Force on Patient-Centered Primary Care Home Standards implementation, which a number of practices are working on. She, as well, has done regional network of care projects for cancer navigation and brings a wealth of experience to the table as well. I'm going to go ahead and turn it over to our excellent speakers for today's webinar, and I'll start with Juliet. Juliet?
Mary, thank you so much. And Amy, thank you for the opportunity to talk with your teams across the country about creating practical assessments in partnership with patients and families. I'm thrilled to spend the next 90 minutes with everyone, and I'm also honored to be joined by Patty Black. So I want to just go over what our goals are for this webinar. We absolutely want to discuss the importance of reviewing the vision, mission, and philosophy of care statements that each of you have for your own primary or ambulatory care settings. Because we have the great partnership of Patty here, we're going to learn how to conduct a practice walkthrough from someone who's done it in practice at Peace Health and understand the actual nuts and bolts of doing that. So this is moving from assessment of the vision, mission of your practice, assessment of the kinds of change initiatives that TCTI is urging in their vision statement and their change package. But it's moving from that to then actually creating an assessment of your environment. And then last, we want to really talk about prioritizing findings, and we'll really walk through a number of assessment types of tools. But what we want you to walk away with is practical, hands-on projects that you can begin in the very near future as you advance the TCTI goals for patient and family-centered care. We want to make you aware that there are a number of resources that have been loaded onto the website, and at the end of this webinar, you'll have the URL so that you can click on and go directly to each of these tools. Patty and I will be referencing these today, and they include a tool that was provided last month, which is Advancing the Practice of Patient and Family-Centered Care. This is really a how-to-get-started guide. It's designed by the Institute for Patient and Family-Centered Care, and it is everything from the beginning visioning to actually creating the first steps of partnering with patients and families and moving forward. We've also included a self-assessment. So, I think one of the great daunting efforts on a self-assessment is where do I begin, what are the questions to write, and how do I even wordsmith those? And we wanted to take that work out of the equation for you, and so we've given you sample assessments. Some of those are in that How to Get Started package, but also in this worksheet in the self-assessment. We encourage you to download those, take them and customize them for your environment, but that will give you the good foundation. We've also included how to conduct a walkabout or an environmental scan in 2 different settings, in primary care and ambulatory settings. And again, use these and customize them for you. That worksheet for the improvement in redesign is also included on the website. And then Patty's made available the Peace Health waiting room observation form that she's going to talk about today. So again, you can take that and make that your own. So we always refer to the journey of patient and family-centered care as it is definitely not a destination, and I can so feel a sense of collegiality with all of you when I downloaded the change tactics for the TCTI released last week, of the sense that it absolutely is a journey. Many of the pages in the change tactic document are filled with beautifully articulated aspirational goals. And so I definitely share this sense of we're on this journey together. In the work that I lead at NYU Langone, it really is about, putting one step in front of another on this journey. I wanted to mention the great webinar that Mary Minetti hosted last month on how to develop practice patient and family advisor programs. That is on the website. You're able to download those slides from February and also listen to the recording of that webinar. If you weren't able to join, I encourage you to do that, because that really is the foundational level of how to be this partnership journey. And that's really what's going to shape all of our discussion today. We all do the work in healthcare every day to advance better care for all, and something very powerfully changes when we do it in partnership with patients and families, and that's our focus. I want to mention, because I know we're all at different places on the journey, some of us, like Peace Health, have great embedded patient and family advisors, partnering with them in the evaluation, design, and outcomes of their care. And some of us may just be beginning, but we all share a commitment to partnership in the moment of care. I also want to encourage you, because we'll talk about some really wonderful examples of formal partnerships that happen between patient and family advisory councils today in primary care settings. But I can appreciate those of you that are on this call who aren't there yet. And I want to encourage you to think today, as we're talking about informal projects, because there really is something about that begins the journey and gets started. So as we're giving you these examples, think of how you might do that next month in a very informal way that is well supported by the foundational information Mary shared last month. So I wanted to start our whole focus of this webinar by bringing our attention to the TCTI goals that were released last week. So this is included under the goal for patient and family-centered care, and that first goal is around patient and family engagement. That in order to be a transforming clinical practice, that we would have evidence of partnership that shows respect for values and preferences of the patients and families we serve. That we provide ample time to listen to the patient and family voice. That we collaborate with patients and families, I would say at the system level and design, but also in the moment of care. And that we're aware of language and culture, and that in patient and family-centered care, it really is never that one size fits all, but that we do this in partnership with the patient and family in front of us, sensitive to their language and culture needs. And so the timing of the release of those specific goals on patient and family engagement was really important with the work that Patty and I were putting together for today, because each of those patient and family engagement goals are related to the content we're going to go over. So I want to take those goals and match them against the Institute for Patient and Family-Centered Care's universal definition on what is patient and family-centered care. The reason I think this is important is I'm sensitive with the teams that I work with. If patient and family-centered care can sometimes sound like mom and apple pie. Like we would all nod. I mean, we've chosen a profession that brings us to delivering care in our communities. And of course, we're patient and family-centered. But I think coming back to the definition is really important, because the definition focuses on mutually beneficial partnerships between patients and families and healthcare professionals. I always, in my training, talk to my teams about those three words that are highlighted on your screen there, mutually beneficial partnerships. And the reason I do is I think in this era of patient experience and patient satisfaction, it's so important for us to understand this work is about partnership, and partnership that absolutely must be mutually beneficial. So it kind of takes us away from that sense of being a hospitality industry. And sometimes when I read patient satisfaction scores, I can feel this pendulum unfortunately swinging to that is now the job of our healthcare professionals. And instead, we want to bring that pendulum right back to the middle. Of course, every patient and family deserves care in a lovely setting that is respectful of them. But this mutually beneficial partnership says no matter where I receive care, and it may not be in the Ritz-Carlton or in a Disney-created healthcare setting, wherever I receive that, what is most important is this concept of partnership, that my voice is heard, that the voice of the clinician and nurse caring for me is also heard, and that we are in this partnership together. So it acknowledges that families, however they're defined, and that's so important in this work that the Institute leads around Better Together, that families define who their family is. As they enter your facility, if their family is a valued next-door neighbor, that we as healthcare leaders embrace the concept that the family defines their loved one or their partner, and that families and patients are essential for the health and well-being, and that they're allies in quality and safety. This is really what takes it away from the patient experience and into an important conversation. Transforming clinical practice in partnership with patients and families is absolutely about better outcomes. So the core concepts that we always use, these are completely linked as the Institute for Patient and Family-Centered Care helps to guide many of the outcome strategies for the TCTI, that these are grounded in mutual respect and dignity, in communication and information sharing, in partnership, and in collaboration. So our focus is really going to be today on one aspect of advancing the journey for patient and family-centered care, and that's in assessment. So I'm hoping that you'll come off this webinar today having a good sense about how you might advance a baseline measure of your own primary care setting in partnership with patients and families to advance a culture of patient and family-centered care. That you'll be able, through the tools that we're providing and the brainstorming that we'll do together, to identify success and opportunities in your own setting. And that from that assessment, have a roadmap for this year to advance the TCTI goals. Many of you may be familiar with a proverb that reads something like, if you have 7 goals, you have none. And I'm always trying to work with my team to say, what are our goals? What are our 3 goals right now? And this really is because, in truth, we're taken off-road, or we're taken on a detour on our journey to advance patient and family-centered care if we are not focused and targeted on specific and very attainable goals. Now, I say that, and I'm really sensitive to the fact that the change package that was just delivered to your inbox is 32 pages long, and it has a lot more than 7 goals. In fact, the pages devoted to person and family-centered care design, the one that we're talking about today, has 12 pages. But that's why this assessment is going to be so important. The truth is there is a lot of work to be done in America to transform care. But what we really have to focus on is what is attainable for you this week, this month, this year. And that's what we hope we can accomplish today, is a methodology to help you do that. I think in fairness to all of you who are trying to transform care in your clinical practice and see patients at the same time, it's only fair for us to really be able to focus and target on what are the things that really are doable for you in the near term. We all know, those of us who've done patient and family-centered care assessments all these years, know that there is such a sense of energy and motivation when we can stay focused on targeted goals and allow your staff, your patients and families to see tangible evidence of this. And there's something about the work that will move faster because we did it this way. So what happens when you take those targeted goals and you do it in partnership with patients and families? And we know you absolutely gain a new point of view. In fact, in the environmental scans that I lead at NYU Langone, I actually order off of a website those Groucho Marx glasses that have no lenses in them. And when we begin our environmental scan, or a walkabout, what we might refer to as a walkabout, I literally order those and have everyone put them on so that we actually feel like we are coming into the building with a new set of eyes. And we pause. If we aren't wearing the glasses, we actually may pause and think about a scenario in our mind of someone who rushed to our primary care site to get care in a late afternoon, knowing that their loved one needed to be seen as soon as possible. And how does it feel for them to walk in our setting? And so in this practice, we really literally are wanting the team to see with new eyes. In the work Patty and I are going to describe to you today, we really encourage you to do that with patients and families at your side, because that's really how that influence happens in that moment. You begin to hear or see things that they see that you weren't looking at when you walked into the building. It's hard to walk into the building that we come to for work every morning and see it differently. So we absolutely gain a new point of view. Whether you're doing the walkabout or the environmental scan, or maybe you're doing the assessment over pizza in one of your conference rooms as a conversation, this new point of view begins to shape how you as a team will begin to think about your care in the future. I think having patients and families, in addition, helps validate or reshape staff assumptions. Without patients and families at the table, all we can do is assume. We can think, and many times we're right. I mean, we're all individuals who studied and who have devoted our profession to understanding the point of view of our patients and families. So often we are right, and many times we either have our assumption reshaped or validated. The other piece that patients and families bring is they help us prioritize. I'm very sensitive that all of you on the call today have precious resources. Those precious resources are the budget that you have to work with this year, but it's also the precious resource of your time. But by doing this in a mutually beneficial model of partnership and having patients and families at the table together, you can decide on where those precious resources are going to be devoted. And that's really a great conversation. It needs to be a dialogue because patients and families need to hear what your priorities are as much as you need to hear what theirs are. And then in all of the work that we've done over the years in designing assessments with patients and families, we've learned that an interesting phenomena happens. So that the call out from the primary care collaborative has been so beautifully articulated to do this in partnership with your patients and families. And as primary care settings have done that, they've noticed that they also begin to include other stakeholders that may have been absent. So look around at your own team and think of the individuals who you may not include in staff meetings or who may not be part of decision making about how you're going to use the waiting room resources or design patient flow, and encourage them as well, and enlarge the table for this work. So I think of three different kinds of assessments. We're all so very familiar with the electronic assessments and the individual surveys. These might be handwritten by your staff. They're often electronic. They may be customized by you, or you may be using standard or, of course, the CG caps that all of us are very familiar with. I think about these because this is where we see a tremendous amount of survey fatigue. Survey fatigue by patients and families, and you can see that in the really challenging return rates of the surveys in HCAPS. But I also think there's a lot of survey fatigue of staff. You know, you get assessments from your professional associations, and so I'm very sensitive to how we approach this to really find a way that that we can work around that level of fatigue. I certainly think these individual surveys, which are usually broad and sent to everyone in your setting, are a wonderful way to get a first blush or a good glance at a broad brush. But the challenge with them not only is the response rate, but the challenge also is that they are unidimensional. These are flat questions. So if we ask a patient or family, I felt supported in the clinic experience in ways that my family needed, we might see that they gave us a top box, but we really actually don't know much about what that support did and what made a difference. Or conversely, if they scored us poorly, what about that was difficult for them? So again, it's a good first blush. Gee, we love to see all of those top box scores, but it is only a unidimensional piece of information. Many of us have complemented those individual surveys with team-based discussions. And the reason I love this is, especially as you look at your staff surveys, so if you send a survey out to all of your team, asking them questions about how well you're doing on patient and family-centered care in your environment, you'll notice often a great variety of check-the-box responses. So I think of a question that might be phrased on your survey, or in fact when you download the Getting Started package, a question that we offer out to you to ask is, do staff and clinicians encourage patients to participate in care discussions and sharing decisions? And so what you might find is every person on your team may actually answer that in a variety of ways. And so I love having a facilitated discussion around that survey question as opposed to a check the box. Because again, I might see physician A telling me that yes, that's done exceptionally well, and physician B saying it almost never happens. And what we want to know is, tell us more about that. Tell me about what that experience looks like. Are families present for conversations, or are they absolutely engaged as partners? And so that facilitated conversation actually lets the team validate assumptions back and forth with each other. If patients and families are at the table, how much richer is that discussion? As a family might say, oh yes, I remember when the doctor turned the computer screen my way to show me what he was entering into my chart, but I didn't think I could ask a question at that point. So now we have a whole different set of information. It says, gee, we're doing some things well that point towards inclusion and decision making, but families are telling us they really want to have permission to speak or permission to ask questions. It might be in their culture that they didn't know that was a time that they could talk about this. So again, it really starts to shape the conversation about where is the targeted need for that question. And then this last type of assessment is so powerful, and that is the walkabout that Patty's going to describe, and that is assessing the environment by walking through it, as if you are a new patient and family. So when you download the resources and tools we mentioned, you're going to see all of these checklists, and I think there's one of two ways that happen. You look at the checklist, and you either feel enormously proud because you're doing everything on that checklist, or you can feel pretty defeated, like, boy, where would we begin? There's a lot to do. And so we encourage you to begin with your strengths in mind. So many of you are probably familiar with the whole field of appreciative inquiry. If you haven't been exposed to that work, go into Google and put appreciative inquiry into the search engine, and you'll have many, many resources that you can use. But as a summary, it really does begin with the strengths in mind. And so we know that this works well because this is a lot to do for you and your teams, and we want all of your teams and you to feel bolstered by what you do well already. In partnership with patients and families, ask them about your strengths first. What is working well? And what would we want to be doing more of? What is it about this experience, this person, this moment in the clinic flow that is making a difference for you, and how can we do more of it? Once you've collected that appreciative inquiry, and that can be done in quick ways in your settings, I'd find ways to share it broadly, and I'd publicly share it with your community so that people can react to it and respond to it. And then I would honor and celebrate the findings. I'd find ways to honor individuals, teams, or moments of care that were indicated during your appreciative inquiry as a really beautiful starting point. Beyond doing your assessment of your area, there's the value of benchmarking. So in your CGCAP, you have that opportunity electronically to look at how are you doing with other primary care settings that look like yours, and there's enormous value in that. I also think there's great value in doing benchmarking outside of your peer group. So that's benchmarking that is still within healthcare. So what does it look like to walk into a Walgreens clinic, or what does it look like to walk into a healthcare setting that is delivering completely different care than you are, and what could we borrow from that experience or make sure that we don't do? And then I think there's great value in looking outside of our healthcare profession entirely. In fact, there was a great presentation at HIMSS last week at the Healthcare Information Management Conference on the use of Amazon-type technology in collecting much more transactional information and power in our healthcare approach. And so the presenter of that was an Amazon leader. And so, what is it about an experience that you might have at your dry cleaner that feels completely different to you and makes you go back to only that dry cleaner? And what is it about that moment and that feel that could be brought to your patients and families to say, how could we do this differently? We know that we want to do better. So when you begin your assessment, you're looking at your mission, vision, and values as a starting place. And we begin this starting place because it's a great way for your leadership commitment to show in a very visible way what matters most. So as a next step after this webinar, we'd encourage everyone to spell out their mission, vision, and values, whether that's on your website or it's on the entranceway as you come into your setting, or in something that might be by the registration desk. Bringing a group together. So this photo was taken at the Medical College of Georgia for their clinical settings about 15 years ago. So it's a dated photo, but they showed early leadership and like you, were early adopters of bringing patients and families to the table. And they rolled out this butcher block paper and allowed everyone to write their vision for what care should look like in the ambulatory settings in Georgia. So it was a very tangible way to begin to think about change and vision and values. So I would take a look at those words and how much do they link to your vision for transformation? How much do they link to comprehensive care that is patient and family-centered, that is in partnership? And then have everyone react to them. What about this vision is the same? Maybe it was articulated 20 years ago. What about it is the same? What missing words actually do patients and families experience in the care partnership with you today that they would want included in that vision mission statement? And then again, I find ways to share that broadly with your community. It may not be practical for you to have a whole retreat as these clinical settings in Georgia did, but you might want to have some butcher block paper in your waiting room and have families as they're waiting for you react to your statement and invite them to take a marker and articulate for you their vision for care in your setting or what they experience in your setting today. As you move from leadership vision in your package for advancing the practice, you'll see great language around assessing partnerships in care. So in this assessment work, it includes the patients can specify who their family and community caregivers are. The families are encouraged to participate in care delivery at the level they choose. The patients and families have easy access to their health information, their care plan, and their clinical team's goals. That they are supported to share observations, their concerns, and ask questions of the healthcare team. And that their cultural and spiritual values and beliefs and their language needs and preferences of patients and families are honored and supported. And so those partnerships and care goals immediately are reflected in your TCTI goals. So I want to turn it over now to my great colleague, Patty Black, who brings such a level of passion to this work and that patient and family perspective that's so needed, and have her describe the work that she leads at Peace Health.
Thank you, Juliet. I'm having a little difficulty advancing these forward. I think someone might be able to help do this. It's just not working for now. Now we'll see here again. Thank you. I'd like to share this morning with two experiences that we had with our Patient Advisory Council. One, we did a walkabout in one of our pediatric clinics. And the second, we are in the process right now of doing some waiting room observations that we'd like to share. To prepare for the walkabout, we had to do a little homework. We all went to our network of friends and our families, and we asked them to visualize yourself entering a waiting room of a medical clinic. What kinds of things do you expect to see that would help you feel more comfortable and safe? And then was there anything that you didn't want to see? And as you might expect, we did hear a couple comments about people not wanting to see dead plants or dead fish. But we took our list and we combined them, and then we talked about them. And we thought there was such good feedback on just from this little bit of homework that we did, that we thought when we went and did our own walkabout that we would look for those things. We started our walkabout at 6 p.m. so as not to interfere with patients and staff. And honestly, we didn't want to include any staff participation at that time because there was a little fear that it might inhibit some feedback from some of our advisors. And we also didn't want to experience any kind of potential pushback from staff as to why something wasn't impossible. Because, boy, we were going to go in there and we were just going to brainstorm all kinds of things, and some of the feedback might have been a little crazy. But we didn't want to inhibit any of that process. And we did realize, though, however, that we were under some budget constraints, and so, you know, we couldn't get too carried away. For the story, we were told to imagine that this was our first time to visit the clinic. We had an infant in a carrier and a 3-year-old toddler in tow. We were to start on the first floor and find our way to the waiting room on the 4th floor. In fact, one of our advisors even brought a couple of props. She brought some baby carriers so we could actually carry and be encumbered by that, and some baby dolls. We broke up into groups of 4. Each group had a scribe, and we also had a videographer recording the whole process. We all started down on the 1st floor at the entrance door and found our way to the clinic on the 4th floor. Now, we all didn't move through this hallway and the elevators at the same time because some of us were really taking a look at the signage that we had outside of the clinic building and in around the elevators. And so you might worry about clumping, but that didn't happen. I'll tell you, we felt we didn't miss a thing. We were looking at artwork, we were looking at signage, we were looking at paint colors, we were looking at even carpet samples, and we were looking at anything that had to do with wayfinding or even plants, like some people suggested. We got into the waiting room and we were looking and moving around furniture to see if we couldn't find the best placement of furniture that afforded the best privacy. And then after replacing the furniture, as we found it, I want to make it clear that we did do that, we went back to our meeting and we compiled our notes. And we ended up with 2.5 pages of comments and suggestions. And then we sorted them into the 4 buckets that you see. One was atmosphere, which was paint color and furniture and artwork, things like that. Then it was directions, had to do mostly with signage. Functions, did the furniture fit the people? We noticed that the fountains didn't accommodate smaller people. Countertops were too high. It was comfortable speaking with another person on the other side. And then safety. Safety had a lot to do with some of the furniture. There was a doorway leading to a back hallway that led nowhere that children could get out if they weren't watched. There was ledges that were too small, things like that. And then after sorting it into those categories, we discovered that it was pretty easy to comment on the order of priority. We rated those comments and suggestions that we felt very important and should be considered as number 1s. Number 2s were nice to do. Number 3s were, we called it save it for a rainy day. And then we put stars next to all those things that we considered low-hanging fruit, those things that we could do with very little monetary outlay. So share the results. We met with the PED staff to share our findings, and guess what happened? They all started to cry. I mean, real tears. And we went, whoa, my God, you know, what did we say? What did we do? And then they shared with us that they felt so supported and so validated that we were coming up with the same things that they had the heart to do and change, and then some other things as well, that they truly felt they had partnership. I have never seen so many smiling faces from our advisors because at that moment they knew that their efforts were validated. So then it was suggested by our advisors that the next step would be for all of their staff to do their own walkabout, just as we did. And then we would get together and would compare notes and we would decide on the next steps. So here you see a picture of what we saw when we first went in to do our walkabout. You'll notice that counter on the left is about 3.5 feet high. So there's nowhere for anyone to put their children, their bags, their belongings. When you look across the counter, across the person in the front office, you were looking down 2 feet. There was no privacy. You can see the colors drab. Now look what we have. We've lowered that countertop. Moms can sit down in the chair, look straight across to the front office staff. Their things are on the floor where they're easily reached. You'll notice the chairs on the right are faced away, affording a little bit more privacy. The artwork is appropriate. It's bright. It's a very welcoming space. And then what did we do? We came back and we wanted to share the experience because it was so profound, and we celebrated. We celebrated that partnership. So the next thing I'd like to share is what we're doing right now in our waiting rooms. You know, because our patient experience really starts there, we decided that we would try to do something about that experience to partner with it to see if there were any opportunities for improvement. And so we designed this template to give us a little bit of an idea of a focus point on those things that we were going to really look at. And one was clinic facilities. And for those are the things that, you know, mean appropriate signage. Are the parking easy to get in and maneuver, especially for those who are disabled? Is it clear? Is access easy for these people? Does the front desk look good and organized? Is it uncluttered? You know, and does it allow for patient privacy? And then the checking in process, you know, does the front office staff appear to be courteous and helpful? You know, can patients see the name tags? Is that personal relationship being developed right in that moment? Are the staff members appearing to be respectful and professional? And can you hear private conversations among the staff? And this was a call out from one of our clinic visitors that this happened a little bit often at this particular clinic. So we're just going to go in and take a look-see. We also have a large area on our template for general comments and feedbacks and suggestions, and one has already been made, is that our patients being seen in a timely manner. And then now we're going to go ahead and collect all of these observations and do something similar like we did with the walkabout in processing what we see, and we're going to take it from there. So Juliet, I'd like to turn it back to you.
Great, thank you, Patty. And lots of great practical examples that held so much meaning. And I loved your call out of low-hanging fruit, because I think that gets to the earlier discussion about, where should we begin and where can we get some of our earliest traction. We mentioned earlier in the webinar about, the fact that we all have precious resources, and I think the walkabout that Patty described is a very tangible way for you to prioritize the resources you have. Just an example, in 2005, I had an operating budget that was used to provide reading materials in all of our family waiting spaces across the medical center that I worked for at that time. So all of the ambulatory care settings, the primary care settings in Philadelphia. And it was a extensive budget because we needed to do reading for different age groups. When we did our own walkabout last year in 2015 in the work that I'm leading at NYU Langone, we learned something very powerfully, and that is that we didn't need magazines at all. What we really needed was mobile technology chargers. So as we did our walkabout, we actually saw in some of the clinic spaces in Manhattan, families sitting on the floor, much like you see in the airport, next to an outlet, because in some of our older buildings, the outlets were few and far between. So here's an example of where the walkabout really guided our budget. And it wasn't about ordering subscriptions to magazines at all, but it was about getting chargers in the primary care spaces. So young patients and their families, who were all on their smart devices as we walked through and did the environmental scan, would be able to charge their technology. I think there's lots of examples of how the environmental scan will really bring to the forefront the opportunity for cultural and linguistic effectiveness that is so core and so well articulated in the TCTI Goals. We know that our families come with very diverse backgrounds, and we really need to have an eye towards what is the health literacy. So we think of that from a translation standpoint, interpreters and a translation of our materials to match the patient population you serve. But we also need to think of it as basic health literacy. This is a wonderful document that you can download if you go to the National Academy Press website, which is part of the Institute of Medicine. So if you go to NAP and you put in a prescription to end confusion, you'll be able to download this entire guide. So it does two things. I think it creates a sense of urgency because they have great evidence-based research here on the levels of health, the challenges of health literacy in America, but it also has some really great approaches that you can implement. We know that it's not just about language, but it's about beliefs and values. So we may say we want to engage patients and families meaningfully in their care, but we need patients and families from the cultures and the belief systems we serve to tell us what that looks like for them and have them tell us how this would work. In all of our health literacy work, it's really about getting down to basics in plain language and making sure our materials, our signage, and our resources are easy to understand, not just because they need to be at a fourth grade level, but because when families and patients come into our healthcare setting, even if they speak our language, they are arriving stressed and tired, and they often don't feel well. And you read differently when you're in that kind of position as you're coming into our centers. We partnered with patients and families to help design how would our approach look differently so that we could communicate quickly to patients and families that we're here to provide resources. So this was some work that what happened at the Children's Hospital of Philadelphia when I was there. We brought patients and families who didn't speak English to the table. And interestingly enough, and it was kind of a comical moment for those of us who are proud of our patient and family-centered care work, but the only place that you could find in the clinic settings where it said that we would have a translator on the phone for a patient or family was inside our little welcome folder. And of course, inside our little welcome folder in English, it said, "We are committed to giving care to you in the language you choose." Of course, that wasn't helpful at all. So it was patients and families who don't speak English, who sat at the table with us as partners, with a translator, who said, "Put the sign right as I walk in the door in my language." So we developed with them these language cards that on the one side say, in their language, so in Vietnamese or in Spanish, it says, "Welcome to the Children's Hospital of Philadelphia. We're glad you're here for your care, and we are committed to providing care for you in your language. Take this to the front desk, this card." So these cards they pick up at the entrance to the clinic. And so that says that in their language. When they bring it to the front desk and you turn it over, it says the parent or patient standing in front of you speaks Mandarin. Please pick up, and at that time we were only using the AT&T language line, but it then gave the person instructions in English on how to access an interpreter immediately. So it was just a great example of how the conversation changes because the right people were at the table. So we want to finish up by saying, share your assessment findings. I loved Patty's celebration poster. Develop an action plan that illustrates your commitment to partnership with attainable time frames. Make sure you're not putting too many things on there. So here's what we can do this week, this month, and this year. And some of them are going to be low-hanging fruit. Others might be long-term projects. Organize it by a focus of domain. So some of these are culture and values and leadership. Some of them are perceptions of the environment, and others are about partnership and care. And then share it broadly. Share it very publicly so your community can comment on it and get the kind of energy and passion behind the work that is going to happen in the future. Use this assessment as a foundation for patient and family-centered care training. We're looking forward to joining you in a future webinar where we talk specifically about this topic. So how would I take my assessment findings and now shape the opportunity to train my staff in my primary care setting about patient and family-centered care? And we believe doing that in partnership with patients and families as co-teachers is one of the most powerful ways. If I learn through the voice, the moment that Patty described when the team began to cry because they saw so powerfully what patients and families wanted most. So I'm going to stop there. We're looking forward to taking some questions and answers, and thank you so much for spending this last hour with us.
Great, Juliet and Patty. What a wonderful presentation and some really powerful examples of partnership between healthcare professionals and patients and families. We have a number of questions, and so what I want to do is we're going to answer a couple questions before the top of the hour, but I recognize that some people will need to leave before 2:30. We will continue Q&A as long as there are questions and answers through 2:30. That Q&A will be recorded along with this webinar, so if you cannot stay and your question was chatted in and didn't get answered, it will be answered during the Q&A session. And so I want to also let you know that you will be receiving an evaluation, and we really want to continue to improve our webinars to you to provide you the support you need to be successful in creating these partnerships with patients and families. So I'm going to start with some questions. Those of you that have joined us and can't stay, thank you for joining us. We hope it's been useful. One of the questions that came up fairly early in the presentation, and Juliet, you can start, but I'm imagining that Patty will also have a perspective to share about that. And it is, can you talk more about how the relationship between patients and providers and this partnership model, as you described, is beneficial to the provider?
Great. So when we think about the advisor relationship, and I know, Mary, this is information that you shared with this audience in February, we think of individuals who care deeply about the care they're receiving in your environment, and they often want to get involved and give back. In fact, that's the genesis that many patient and family advisors get involved. They want to make a difference. They begin really as an advocate in their own healthcare or in their loved one's healthcare. And through a process of bringing them on board thoughtfully and preparing them to be advisors. So this looks different than a focus group, or it looks different than, let's say, a session where families might have a grievance, or they're in this mindset where, oh, I'm going to be complaining about the environment. But the work that the Institute for Patient and Family Centered Care leads and the resources that they have says that many patients and families want to partner with their healthcare professional to say that we can shape this care experience differently. We encourage you to prepare those advisors to be your partners, and that does look different, and they do need preparation. And so, again, turn to the tools that are provided through the Institute to find out your best recruitment strategy for those patient advisors. When they're given some information, so there's a wonderful book that Mary helped to author at the Institute called Words of Advice, which is a book for patients and families who want to be advisors. When they're prepared for that work, they have extraordinary benefits to offer providers and clinicians. And again, it's where the conversation begins to change because they're present. I think we can all call upon our own healthcare experiences when we've been sitting in your own doctor's office. So now changing the hat of being a provider and now being a patient. You have things to share about how that experience went for you, and that's what providers have benefit from. I also think there's this beautiful benefit to, like we talked about, the appreciative inquiry, to hear about what's going right. What are all the positive things? So I'm hoping that answered your question, but those are some of the quick benefits of the unique partnership with advisors.
Great. Thanks, Juliet. Patty, do you have something to add? I know that you started as a patient advisor.
Yeah, I can. You know, we in terms of messaging to our providers, we have opportunity as patient advisors to share with our providers that our main role is to help us be better patients, and that we care as much about your experience in your work as we do the patient experience. Because when you're happy and fulfilled in doing the work as a provider for us, we feel it, and we know that. So we're going to do everything we possibly can, you know, to get us there, you know, in partnership together. We've offered, one group of our patient advisors have offered to come in on a couple of Saturdays, and they've done this to do role-playing models, to give providers opportunities to practice new ways of doing something in an actual exam. So anything that we can do to help, our patient advisors are more than happy to do.
Great. Thanks, Patty. And I know from my experience as being a quality director of a multi-specialty practice was that there are a number of providers who really appreciate having patients at the table, and it's energizing. I have one provider who said, I go to lots of meetings to improve things, but the meeting that is most meaningful to me is the one where patients and families are working in partnership with us to solve problems and solutions. They often come up with ideas that are less costly but really help meet everybody's needs. A very practical question came up. Either of you, I know, are able to answer it, and it's just simply, how do you select your patients and families for this input? And this question came in at the point of talking about walkabouts. So think in terms of walkabouts, how do you select people? But then you might speak more broadly to for other kinds of activities.
Sure, Patty, did you want to start with that one?
Yeah, I can. You know, when doing a walkabout, I really try to go to our patient advisors that have experienced in their lives a disability, either with themselves or with a family member, because they can look at that walkabout through a different set of eyes based on their experiences. So it's wonderful to include them. It's wonderful to include people whose English is you know, a second language, because they also have a different perspective. So I guess when I'm trying to put together, you know, a walkabout, the many different perspectives are really important and valuable, and I try to get people together like that. Different ages, for example. That's also another thing that I look for.
Great. I think those are great strategies. Some broad things that I might say, if you've never reached out to a patient or family to begin this practice advisor concept, I might talk amongst yourselves. There are characteristics that we all know make for good advisors, and those are individuals who are respectful, individuals who are good communicators, individuals who have great listening skills. People who are able to hear diverse opinions and are able to share in a broader view. And so I'm always cautioning people that that isn't about a degree. It's not about an educational degree. It's not about a level of school that you've completed. That's about the spirit of the person. I would talk amongst yourselves and say, gee, who comes to mind and that have those characteristics? And then I'd also think about people who are speaking up in respectful ways with you and the team about the care experience, about what they liked, or maybe they've given you a suggestion. Maybe they've written some comments on a feedback form and you all took those comments to heart. And I'd start with those individuals. I'd also recommend starting small. If you've never done this before, I'd identify maybe 3 individuals in your community. They may be patients themselves or maybe loved ones, parents or children of the patients you're serving. And I'd describe this role to them. I would describe to them that you're embarking on transforming your clinical practice, and I'd be very specific, and I may not even use the word practice advisor in the beginning because most people walking into your clinic don't know that word. I'd say we want to do this in partnership with you, the patients and families we serve, and we're wondering if you'd be willing to come to a meeting where we begin to think about this. And that's how small I would start and get comfortable with that experience with the 2 or 3 people that you could identify that meet those characteristics. And then from that I would grow. And again, I can't overestimate the number of resources that are available on the IPFCC website about recruiting patient and family advisors. If you have a chance to come to our seminar that we're going to be hosting in Chicago in 2 weeks, many of you I know are coming, but those of you that are on the call that may not have signed up yet, we will be doing a deep dive into this topic in a number of sessions, all of the nuts and bolts and how to recruit for TCTI specifically and how to partner with patients and families. So we'd love to see many of you in Chicago the first week of April.
Great. Thank you, Patty and Juliet. We have great questions coming in, and here's one that either of you can take, and I'm also happy to speak to patient activation. But the question was, I've been hearing a lot lately about the difference between patient and family engagement versus patient and family activation. Can you describe the difference and if this is something you're working on?
So I don't want to overstep, Patty, but I'm willing to take that on. I think about this question a great deal, thanks to whoever sent this in. Because I think for all of us leading this work, we can get really trapped up in semantics, and we're literally deluged with new terminology in this field, whether it's activation or engagement or the other, you know, is it experience? Is it patient and family experience? Is it patient and family-centered care? So I really feel the pain that you're sharing about what is the difference between all of this. So the word patient activation, the first time that I ever encountered it was in Judith Hibbard's great study on does it make a difference if I engage this patient differently? Will they be more activated in their health care? So I absolutely think if you read that study in Health Affairs from 2013, that if you took out the word activation and put in the word engagement, you would read the article and have the same, you would draw the same conclusion. So I think it's like, for me, a little bit about semantics, activation or engagement. What I might say is some takeaways of why I would use the words differently. Judith Hibbard's work so focused, and I don't really actually see the word activation in many other settings. You can enlighten me on this call if you are seeing that. But what it really looked at as was a way to measure my actively managing my own illness. So if you look at her scale that she created, the patient activation measurement tool, what she was looking at was, am I going to take my medicine? Am I activated to take my medicine? Am I activated to follow the physician's instructions? So a lot of that was about self-management. If I pull the camera back, I think of engagement as much more of a philosophy of care, and I really think of engagement in a patient and family-centered way. So I think that I might be activated in adhering to my care plan when I get home, but the engagement is around the partnership. The engagement is around that mutually beneficial partnership between a nurse, a physician, a therapist, and me as the patient, or me as the family, and that I am supported in that partnership. So that, I think, is a much broader piece around sharing decisions, sharing information. So I hope that maybe provides some background.
Great. Thank you, Juliet. Patty, did you have a comment that you wanted to make about that?
No, I think for me, engagement really also encompasses a larger partnership with the patients, not only at the individual and family unit and patient care, but also in healthcare in general.
Great. And I would just make one additional comment, since I worked with Judith Hibbard when I was at Peace Health, and we actually used the patient activation measure, which is a validated tool that individuals can take, just like in a practice. You might be screening people with the PHQ-9 to see what the depression, whether they have depression or not, and how severe it is. Judith describes patient activation as three components coming together. It's my knowledge of my illness, it's my skill, and it's also my confidence. How confident do I feel in being able to manage my health over time, over different circumstances, with stress and without stress? And the measure that she created, that she calls the patient activation measure, really can help you identify with patients using a screening what level of activation they're at. And depending on what that level is, the interventions that will engage them and help them become more effective as self-managers are different depending on their levels. And there are a number of articles about that that are out there. And Peace Health Medical Group actually uses the patient activation measure. And there's an article, if you were to Google Team Fillingame, F-I-L-L-I-N-G-A-M-E, the University of San Francisco did a case study on how they use the activation measure in a primary care practice to improve health outcomes. So we're going to move off of that, and we have more questions. So there were a couple comments related to your wonderful description of what happened in the pediatric walkabout, Patty. And one had to do with, it was a comment from a physician who owns a practice, saying that it appeared that the suggestions related to the walkabout would have cost hundreds of thousands of dollars and may not be something that's available or practical in a smaller practice. I know Peace Health Medical Group's a larger practice with many physicians. And then someone asked specifically, do you have any sense of how much the walkabout cost in terms of being able to respond to the suggestions of the advisor? So do you want to respond to that, Patty, please?
Sure. Yeah, no, actually it didn't. Our advisors were very conscientious about the budget, that we thought we couldn't tear down walls or do anything like that, that a lot of the suggestions made were, I'm going to say, cosmetic or, in function and safety and things like that. So no, it ended up being not that costly. It doesn't cost a lot of money to change a paint color. And but in fact, you know, Peace Health took it to heart, and they did tear down a wall and built a new counter. So in our clinic, you know, we could have that relationship building and that ease and safety concerns met. So it you know, I don't have those numbers to say, but you know, paint color and changing out a chair and looking at the safety concerns and making sure the outlets had safety things put in, and moving a bookcase out and from a very dark corner and adding a light, because there was, you know, a real push on reading. And there was, in this particular waiting room, they had the reading shelves and the books kind of tucked away in the back corner where it was very dark, and so the suggestion was to move it out. So actually, no, you know, you can look at things like that, and you can put a cost factor on them, and then take a look-see. I have, you know, if anybody would like to send me an email, you know, I have all the suggestions that were made. I'm happy to share those with anybody that would like to have those.
Mm-hmm. Great. Thanks, Patty. I appreciate it. I know that I would add. So, go ahead, Juliet, please.
I was just going to say the one thing that I would add to Patty's response there is that I would actually be transparent about the resources you do have. So what I hear in that question is the acknowledgement that you've got limited resources, and maybe opening this environmental scan up or this walkabout is going to ask for things that you might not be able to do. I think what's so powerful about this work is if you say, you know, we're embarking on making some changes to the practice this year, and we can't do it all. But through this walkabout, we are going to prioritize, and we want to hear from you. You know, we've got $30,000, or we have $10,000, or whatever it is. Where would you, you know, where should we begin? Where are we going to get the most return for that investment? And I think that that helps your advisors feel very much a part of the equation. This isn't just about a magic wand. We're not going to be able to do everything, but we want to do what we do this year. We want to do smartly with you.
Great, great. And there was a question again related to the walkabout as to whether or not there were a series of questions that you asked as you stopped at each part of as you were doing the walkthrough, Patty. And I know there are some general questions within the handouts that you are receiving today. But did you specifically, Patty, would you have a set of questions specific to that walkabout that you might be able to share?
Yeah, no, not with this particular walkabout. We had done the homework, and so we knew there were certain things that people were looking for that made them feel more comfortable. And so we were looking to see if those things were in the waiting room that we saw. But no, we really kind of wanted to do this particular walkabout with free brainstorming. Anything and everything went. And it was a lot of fun. You know, it's important to do these things and have some fun. And so, I mean, people were coming up with some pretty outrageous things. But the neat thing about that is it made somebody else think, oh, well, wait a minute. I don't think we can do that, but what about this? And so that, you know, that was a lot of fun.
Great. Great.
I will add that the handouts that are on the website right now that are called How to Conduct a Walkabout has some of the questions that you might be looking for.
Great. Thanks, Juliet. So we have another question. This individual asked, have you ever used secret shoppers? And they go on to say that they called their local information number and had a coworker who speaks a native language call in with the native language because they wanted to see what the experience was, and they were able to get an interpreter on the phone in 20 seconds. So it was just an opportunity to, you know, kind of test how they were doing. But have either of you in your organizations in partnership with patients used this particular approach?
Well, we have. Oh, go ahead, Juliet.
So I'm very familiar with secret shoppers. I think that they are very, you know, much more common now in healthcare. I think that they do have a place. I also have a professional bias to wanting this to be work that everyone does together. One of the challenges I think that happens in a secret shopper environment is in some ways it actually can create a level of distrust. of not only the staff that you work with, but I think also of the feedback. There's something very different that happens when patients and families are included at the table as your partners in this work, and a level of trust and honesty that happens. So I'll be fully disclosive. I have a little bit of a professional bias. I do think that especially in access to healthcare and in large call systems, I can see the value. So if your healthcare system is fielding hundreds and hundreds of calls a day, I think having secret shoppers call in helps to do a point of, in that same way that when we call Comcast or Verizon to maybe figure out if we can get support with our cable system this weekend, you'll hear, this call may be monitored. I can see a place for it, but I do have a professional bias, and so wanted to disclose that.
Thanks, Juliet. I appreciate your transparency. Patty, you said that T-Cells had used secret shoppers. Can you kind of describe that process?
Yeah, actually this observation work is very much similar like a secret shopper. But, our clinic managers, they know we're coming. They know that we're going to be popping in and out of their clinic waiting rooms Monday through Friday from the start of business to the close. We aren't announcing ourselves. We're just there. But if any of the clinic staff ask us if they can help us, we're certainly going to say, well, introduce yourself. I'm a patient advisor, and I'm here just doing an observation. And to be real transparent about what you're doing, because it's not necessarily in secret. But I agree with Juliet that we have done call center kinds of secret shoppers. And one project we recently did was to help some work with being more transparent about cost of services. And so we were giving, I think 7 or 8 scenarios of an experience that a patient might call in and ask about to a certain number. And our advisors were really good at thinking outside the box. We gave them a phone number and said, okay, call this number from 8 to 5, and this is, your scenario. You're calling in about a colonoscopy and so on and so forth. And they said, well, if I didn't have this number, how would I get to where I need to be with financial services? And they experienced in different ways and brought to us, oh my gosh, if our numbers were not correct on our website, the menus didn't even ask for the things that they needed to hear in order to get to the next step. And so it ended up being a really great experience.
Great. Thanks, Patty. So here's another question from a fairly large ambulatory place, and this is it. Have you used a regional advisory panel to provide insight across multiple ambulatory clinics? We have individual clinics creating advisory panels. This will be difficult to sustain across 380 clinics. What are your thoughts about this? How might you organize some partnerships in a way that is not burdensome but is useful and meaningful for everyone involved?
Wow, that's
Juliet,
a good question.
It is a good question. Juliet, could you speak to it first, because you've worked in some pretty large facilities with lots of different units and things.
So if I understand the question is, how would you bring patient and family advisors across multiple sites, multiple geographies? Is that right, Mary?
Yes, yeah. To think about a regional advisory group rather than individual geographical groups. Yeah.
Great. So I know many of you have already logged on to the PFAC, which is the Patient and Family Advisory Council, that is a virtual council. And we have a beautiful primary care, PCPCC, collaborative of a virtual advisory council on the PFAC listserv, and that's all on the website for you to link to. The reason I bring that up is I think there's a real place for virtual advising, and I especially think that now that it's 2015. So I've been doing this work for about 23 years, and I began the first Family Advisory Council at CHOP before there was any such thing as Facebook or Instagramming, and I will tell you that increasingly the patients and families that I'm recruiting are from the millennial generation who are saying, you know, I don't really need to come in on the second Thursday of the month and travel 60 miles to get here to tell you what I think and feel. Let me do that virtually. So many organizations with your aim to bring a regional council together are looking at technology. I'd encourage you to get on to the degree that it is useful for you to begin conversations on that PFAC. The region is our nation's primary care, and you can begin asking questions of that group. But then you might want to take that same virtual model and create your regional virtual advisory council. I think that it's going to get you halfway there. You're going to be able to get large input across diverse settings, these 300 sites that you're talking about, and you're going to be able to host some conversations. Happy to talk to you, whoever this is, in more detail about how you can do that in a very secure environment. We set this up at in a large setting in Delaware at AI DuPont Children's Hospital under the Nemours Foundation for Children. We met all of the requirements for their organization's firewall and safety of family information. But you could begin the conversation there. And by stimulating engagement on a virtual council, you might have a face-to-face meeting 3 times a year where that group comes together and works for a couple of hours on some meaningful topics that have happened on that virtual council.
Great, thanks. So there are a couple of kind of logistical questions. One is, are there brief examples of brief assessments available on the website or tools to use as direction on building your own? And so the answer is yes. The resources that were listed in the presentation slides, which are the Getting Started Guide, the Walkabout Guide, kind of a worksheet. The worksheets. So those are all on the TCTI website. That you've got the URL in the chat room, and so you can go and get those, and they are brief assessments, and there are just different aspects in the Getting Started Guide that assess different parts of your practice. And the slides will be on the website as well. So I just want to make sure that you understand that some of the things that we've been referencing are already on that website, and you can go right to it. There's one other question, and if anybody else has a question, because we are just finishing up, we may be able to take 2. There was a question about being approached by one of the TCTI groups that were awarded for Texas, but they've not been able to get their practices enrolled yet, and so you're trying to get enrolled. And so we really encourage you to do that. We also want you to know that as you are getting involved in the TCTI project, our special area for patient and family advisors to join the PFAC network is one where we can provide some support and ongoing coaching to advisors. We really recommend that, especially from a smaller practice, and you might not have a large group of advisors working together, it can be really beneficial for advisors to connect with other advisors across the country who are working with practices in similar ways, just like you are coming to this webinar to learn about how different organizations have worked with advisors, and that gives you as a healthcare professional some ideas about what you might do in your practice. The opportunity for advisors to network with other advisors can be really, really powerful. And there was a comment that I just want to clarify, and that was that the whole idea of the walkabout is a great inexpensive way to get consulting perspectives from the people that you serve, as opposed to having to hire a consultant that costs a lot of money to come in and give you advice about how you might change the look and feel and the welcoming of your practice. And the nice thing about involving patients and families in those walkabouts is each region and each clinic has its own culture. and population that they're serving. You really want to be sure and include your patients and families because they can represent what to them means welcome, what to them communicates partnership in the built environment and also in the processes. Whereas a consultant may be coming from a whole different angle, and besides costing more, they might miss the boat because they don't really understand your community the way that the people living in your community and partnering with you can understand. So I'm thinking that we have answered most of the questions, all of the questions that I'm seeing on the area, which is perfect timing because it is just now the half of the hour, and so we want to be mindful of your time and want to thank you again for joining us. I want to thank Juliet and Patty for being the experts, the people in the trenches who really have done this work for many years and have created amazing advisory programs and partnerships with healthcare professionals and the people that they serve. So thank you all for joining us today. If you have members of your clinics that weren't able to join, remember we do have all the information recorded for the webinar, and they can join late but still get the information so that you can have a really meaningful conversation in your clinic with your team about what might be possible. So have a great afternoon, and watch for notification of upcoming webinars because there will be more. Thanks so much.